The content of this podcast is based on medical fact and evidence-based practice from credible, authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety.
Hey everybody, Eric back with you. Today's podcast, we are joined by Dr. Michael Lauria. He traveled here to Kentucky to work on a new course that we're doing. How you doing, buddy?
Good. Great couple days.
Tired?
Yes.
Yes.
Definitively, yes.
Yeah. Well, if you were at FAST, we did a talk at FAST called FACTORS. And really, FACTORS is an acronym that I would say that Mike and I came up with together, because I definitely couldn't have come up with this by myself. There was definitely a lot of pieces that you helped me, fit together, those puzzle pieces that were missing. Really, the focus is impacting the Platinum 10, and we'll talk about the Platinum 10 in the post-intubation phase. So where did this come from? This came from basically the concept of -1A. In the aeromedical environment, you have a focus on collecting data and evaluating different programs against each other anonymously through gamut data. And one of those areas is -1A. And -1A is first pass success without desaturation or hypotension. And so we really focus, I think we do a really good job in the peri-intubation phase. I think we've come a long way in teaching good resuscitation techniques, good airway assessment, and slowing our airway management down and making sure that we're going through those core areas that could cause us to see a decline in our patient. But -1A, if we think about first pass success without desaturation or hypotension, we're looking at that from the perspective of two different numbers. Number one, we want to make sure we resuscitate to a systolic greater than 90 or an SpO2 greater than 90 before we attempt intubation. And we never want those two parameters to drop below those two thresholds. But it's also important to understand that that is also measured after intubation. And I think that's where this talk and the FACTORS acronym comes in, and what we want to talk about. I love that Mike's on the podcast, because I think what we want to highlight, Scott Weingard's really focus of hop killers, that was really focused on the peri-intubation phase. And -1A focuses on what is that 10-minute period after intubation. And that's what we want to talk about, is the 10 minutes after intubation is a pivotal time. There's lots of evidence that we're going to highlight. And really, that is the emphasis of this talk. During that 10 minutes after, -1A also is saying if you have a drop in systolic less than 90 or a drop in SpO2 less than 90, despite you having first pass intubation success, that's a failure. So we want to resuscitate up to, that measured 10 minutes after. So I'm going to hand it over to you, and what are your initial thoughts on those concepts and those two phases?
I think you hit the nail on the head. And I think the thing that I always, and I would say more and more I'm looking at, is that period after intubation, for a number of reasons. One, like you said, we really focus on the time leading up to the intubation. We get the tube in, it's secure. We kind of have like this relief, but really a lot of the data around peri-intubation events, a lot of those bad events happen after the tube goes in, after someone switched over to positive pressure. So there are numerous studies that look at things like the association of different events or clinical signs, symptoms, or markers with post-intubation cardiac arrest. Some of those big ones we already talked about. Scott's mentioned hypotension, hypoxia, certain patient characteristics like obesity or multiple attempts at intubation. Those are kind of there before and after, or multiple attempts is during the actual event. But hypoxia and hypotension, all of those are up to 10 minutes after the tube is actually placed. Now, the thing that gets me concerned is looking at a lot of this data, the rates of complication are pretty high. So you look at the Intube study and what the Intube investigators did. They looked at a lot of emergency intubations in the ICU and the ED. the complication rates, including hypotension and hypoxia in those studies, were really high, like up to 40 some odd %. And the literature seems to be fairly consistent, talking about complication rates in like the 28% to 40% range. That's almost half of intubations. And those are in the ED and the ICU. Practically speaking, as a flight physician and former flight paramedic, I can tell you, think about all those times you tube somebody and you're walking them to the ambulance, about to load in the back of the 135, and it's in that critical time period, in that 10 minutes, that someone gets hypoxic or hypotensive, and you're squeezing in blood, or you're trying to grab some epinephrine and then make some push dose pressor or whatever.
Yeah, and really that is where the Platinum 10 came in. If you were an early listener to the FlightBridgeED Podcast, we did a podcast, probably the top first 5 or 10 that we ever did, where we focused on that 10-minute scene time and trauma, and maybe getting off scene quick and managing the airway in flight, right? And we've done podcasts since then to really dispel that. And so I used that for a reason. I used that to highlight a previous podcast that we don't really believe in that concept anymore. I think you hit it on the head. We're missing a critical phase. That critical phase is when we're moving our patients from point A to point B. We're focusing on all of those situational awareness focused areas that we have to pay attention to. Are you loading your patient hot? Are you on an LZ? Right? Do you have lines? Is it at night? Do you have MVGs on? You're worried about your surroundings. You still have to worry about your patient, and that's that 10-minute phase. And I love this quote by Napoleon, and you had brought this up when we talked. The most dangerous moment comes with victory. And so the victory is often when we get that intubation. All right, we've secured it. We have ET tube confirmation. We have end-tidal CO2 waveform capnography. We've packaged. We're ready to move. Mm-hmm. Do we drop our focus? Is that a time that we should be hyper-focused? And really, that is where, when I came to you with this idea, where really my mindset was, and again, I have to thank you for helping me kind of bring my ideas together to where I could come up with, a kind of a straightforward focus. And that's where we came up with the FACTORS acronym.
I have to say that I can't agree with you more. And that psychological concept, I think, that Napoleon touched on a long time ago is still true today. And I see it in the military, right? One of the times that I think I've seen bad things happen is you're on target, you clear a house, there's this giant sigh of relief, you think everything's secure, but you're really not secure, right? You're not back at base. You're still in a very high threat area, even though you're not getting actively engaged. And I think the same is true in the ICU, in the ED. We see it when we cannulate patients on ECMO. You're like, oh, they're on ECMO. The sats get better. Everything gets great. And then you start seeing major complications. So after like any sort of major victory or definitive, not even definitive, but fix, win, completion of a procedure, there's this collective sigh of relief, like, oh, we got it done. Oh, we got them on ECMO. Oh, we got the tube in. But the party's just starting at that point.
And I think you could say that in life, right? It's easy to get excited about an accomplishment or anything that we do. We see this in sports, right? And we drop our guard, and that's when a lot of times bad things happen. Well, why don't we go through the acronym and kind of, we're really going to focus on this. I think, this is going to be a novel type of an acronym that hopefully we can expand on. We're going to write a paper on it and or write an article on it and try to really push this as a focused area of -1A. And I've been very deliberate in recent interviews and recent meetings to ask different colleagues, whether those are flight nurses, flight paramedics, or managers within an organization, to define -1A for me. It's really easy for them to define -1A from the peri-intubation phase. We have not done a good job, and I look at myself there. As an educator or an administrator or a consultant, I haven't done a good enough job explaining to the standard medic nurse in the field what truly -1A is, and we're missing that critical phase, again, that 10-minute area. So the first piece of FACTORS is probably one of the biggest impacts in this whole acronym, and it's that transition from negative pressure breathing to positive pressure. So what are your thoughts on that?
Yeah, so this one is very challenging. And I think I take into consideration the underlying patient pathophysiology, right? Because some patients, for example, morbidly obese patients, they just completely de-recruited. They need more positive pressure. They need to be recruited. They may need to get their PEEP titrated up. Other patients, like trauma patients, patients that are profoundly hypovolemic, you may need to be very, very careful because remarkable increases in intrathoracic pressure can drop their preload, drop their stroke volume, drop their cardiac output, and cause them to be profoundly hypotensive and even arrest if there's too much pressure. So thinking about the patient's individualized physiology, do they need less positive pressure? Do I need to be more cautious as I titrate that pressure up? Or do what they really need because of their profound heart failure or morbid obesity is potentially more pressure.
Yeah. So when you think about the impact on venous return and the change from negative pressure breathing to positive pressure, what do you feel like is the biggest area that we should be focusing on? Is there anything that we can do to prevent that impact, or is that just a piece of the puzzle that we have to know that it's going to happen and we try to overcome that with, other type of measures?
Really good question. I think it's probably more of the latter, especially in like an uncontrolled pre-hospital setting or an ambulance on the side of the highway. You have to kind of put together the clinical pieces with the history and the patient trajectory leading up to the need to intubate them to really put the pieces of the puzzle together. And then I think it comes down to effectively managing the other things so that they can tolerate that positive pressure. It's hard, and in some instances, inside the hospital, people have actually advocated for things like awake intubation or awake facilitated intubation and a transition to positive pressure with someone who's either completely awake and with you or mildly or just very gently sedated in order to have a little bit of anxiolysis and tolerate a more or less awake topicalized intubation. That, I think, is really not possible by and large, especially in the field, maybe with a well-trained group of people. Otherwise, I think you're basically just trying to optimize all of that other stuff, optimize their intravascular volume, use other methods to decrease their pulmonary vascular resistance, using inotropes to improve their cardiac output if necessary, tweaking all those other factors so that they can actually tolerate the positive pressure and just being cautious as you're going up on it.
Yeah, and I think that comes back to also the peri-intubation phase using, we teach here at FlightBridgeED the Heaven criteria, focusing on those core areas that can kill the patient. We make sure, and it goes along with -1A of starting off with hypoxia and moving through extremes of size and good positioning and sanguination, et cetera, and go all the way down. But I want to also touch on the difference, and this is going to be, I think, a focused area of the importance of transitioning from a BVM to the ventilator as quickly as possible. And I think this is something we've seen progress in a positive manner over the years. I look back at 20 years of flight. My early flight days, we bagged our patients 99% of the time. We had auto vents on the helicopter, right? And then we progressed to LTV 1000s and then the Revell and, et cetera. And now we're majority of the industry's Hamilton T1s. But there's still, I think, especially in trauma, a mindset of we're definitely not taking the ventilator to the ambulance. Mm-hmm. I mean, I'm just going to say any place I've worked, that doesn't happen. We're taking it to the bedside on a transfer. But in a trauma situation, we're usually bagging our patients to the helicopter, or in some cases, there's programs that are still bagging the patients and leaving the vent in the aircraft on a trauma and bagging them to the trauma bay. There's a big difference in how our interthoracic pressure is optimized or is hindered. And I want to talk about that and how big of a deal that is.
Yeah, I think it's a bigger deal than we've recognized and acknowledged over the years. I think we've taken the fast and furious route and trying to be like, get in there, get on scene, bag them, get out of there, get them to the hospital. I've literally heard paramedics and nurses, both when I was a flight paramedic and even now, and be like, well, the vent never saved anybody. We can just bag them. I think there's a lot of problems with that. First, there are a number of studies that show that we underventilate people, we overventilate people, and several studies looking at profound swings in intrathoracic pressure, or at least pressures on the bag, when people didn't realize what they were doing, bagging, breath stacking, not really paying attention to things, talking to other people. And that's not because I think our providers are stupid or dumb or can't manage it. It's just because these flights, these scenes, people are talking to you, they're asking questions, you're loading a patient in the aircraft, you're directing the ground EMS team. We are just human, and we can only pay attention carefully to so much at a time. And I think we've shown that we really can't pay great attention to the volumes. We can't pay that great attention to the pressures. And I think that in a lot of cases, especially scene flights, there are certain pathologies that we know are sensitive to changes in CO2 and pressure that we got to be really careful about, like head injuries, traumatic brain injuries. We know that overventilating or underventilating people can be really, really bad in terms of secondary brain injury, right? So I actually think more and more, and I was very resistant to the concept at first, more and more am engaged, and maybe we should be bringing the vent and we should be putting them on it sooner than later so we can effectively manage and monitor their pressures, the volumes we're giving people, and the PEEP that they're getting. People say, well, the vent never helped anybody. Well, that's true. I can't say there's any data that suggests a vent actually saved someone's life. But the point, I think, is that especially with today's ventilators like the Hamilton, we can see, we can measure, we can drive our interventions off of the feedback that the ventilator is giving us. Yeah. That's important. It's like saying, well, a speedometer never really helped you, so why don't I just duct tape over the speedometer on your car? Well, you don't know how fast you're going or what you're doing. Precise measurements of pressures and volumes and flow can give you important feedback that may be able to help you with some of these patients. And I think that is important.
So one of the areas that we talked about pre-fast, and you highlighted this, and it was something I learned, we teach this in our courses, that we know the BVMs nowadays, and they have for a long time, have that mammometer set at 20 centimeters of water. And you highlighted a study that you're saying that now they're thinking the gastric sphincter opens maybe at 15 centimeters of water for certain people. Can you elaborate on that? Yeah,
there's been a couple of studies in the anesthesia literature that I don't recall exactly where the 20 came from. There was a paper some time ago that talked about it, but it was another one of those classic papers where it was largely theoretical, as I recall, and not necessarily meets the standard of what we would call robust evidence today. There have been papers that have shown that the esophageal sphincter can actually sometimes open at higher pressures, so it may not open till pressures above 20, but there were definitely documented instances where it opened below 20. So we really, the 20 might be sort of an average, but even as an average, there may be a substantial subset of patients that are still experiencing gastric insufflation at pressures lower than 20 centimeters of water.
I get it, right? It's another piece of equipment you got to move. It's something else you have to deal with. But I think when you think about, especially if the majority of the industry are using Hamiltons, and again, I understand we have listeners all over the world that you might not use Hamiltons. If you have a ventilator that's giving you consistent feedback, it's giving you your static compliance, it's giving you an inspiratory resistance reflection, it's giving you the expiratory, the RCX, and giving you an expiratory time constant, right? That's not going to be utilized for every patient. So you have to, what I try to teach in classes is these parameters should not be an aha moment for you. You should understand the disease process, the patient you have in front of you, and these should be confirmatory. You should suspect, hey, I've got an ARDS patient, probably likely going to be low resistance, but poor compliance, right? They shouldn't be these aha moments, but they're great for confirmation. And I think understanding your loops and your graphs and understanding your waveforms adds just another element of your ability to take care of your patient and see things from just a broader perspective.
Yeah. And I would add that I don't think there's any definitive data that doing it and putting someone on the ventilator in the pre-hospital environment is shown to be beneficial. But I think there's substantial literature that suggests things like, for example, managing end-tidal CO2 or PaCO2 in patients with traumatic brain injury. It's enough that I think there's equipoise at this point to study it. This is something that would be great for an initial retrospective review of patients that got put on the ventilator before they got loaded in aircraft versus patients that weren't, and potentially even studying in randomized control fashion, randomizing by various methods whether or not the air medical team bags them to the aircraft and then puts them on, or bags them to the hospital versus puts them on the ventilator right away in the back of the ambulance. That would be a cool study.
It would. Well, that leads us to our second tier of factors, and that's hypoxia. Obviously, when we're talking about hypoxia, we're talking about patients that have an inability to have proper gas exchange. We'll just say oxygen moving across the alveolar membrane and reaching the red blood cells. Now, that could be hypoxia for multiple reasons. Could be hypoxic hypoxia, hypemic hypoxia, which trauma patients, you're probably going down that road. And then you get into stagnant, and you get into your patients that maybe are histotoxic, right? So we have 4 levels of hypoxia that we should always go back to and just completely reassess. But you got to think about hypoxia and think about, do you have a de-recruitment issue? And I think that's an area also that we have to remember is what phase of your ventilation is recruiting alveoli. We often talk about PEEP, but remember PEEP is maintaining that recruitment, and there's also a trade-off with PEEP. PEEP is going to add interthoracic pressure to your patient, and it could have a negative effect hemodynamically. It doesn't mean that you withhold PEEP, right? I want to talk about that. I think the transition from an adult BVM to mechanical ventilation. How big of a breath do we give with an adult BVM? I think it's fallacy to say we're giving 500 to 600 mils per breath. So if we're giving a big 12 to 1500 mil per breath, and that definitely happens, and then you set a patient at lung protective tidal volume ranges, you have a huge reduction in tidal volume. And I have seen multiple times patients desaturate simply based on that transition. So I want to talk about that. I want to talk about supine versus head of bed elevated, the loss of recruitment when we lay our patients down, and then the underlying pathophysiology that you're dealing with.
Yeah, so you have to walk me through the all 4.
So de-recruitment.
So is absolutely going to be a thing, especially if we're doing rapid sequence intubation, which I think is in fact the case the vast majority of the time in the air medical world, right? And I think that it is difficult to say exactly, because again, one of those things I don't think necessarily be studied on the side of I-25 in New Mexico, for example. But there's a really good chance they're going to de-recruit following intubation. How do you optimize them afterward? Well, I think it's a function of setting them up, finding that optimal PEEP, and I think that recruitment maneuvers in people with healthy lungs in the OR, okay. There have been some studies in the anesthesia literature that say it's safe and reasonable, and I believe them. Patients with sick lungs, it's not been shown to be helpful in ARDS, and has actually been shown to, or is no longer recommended, is recommended against by multiple international bodies. So the question of actively recruiting lungs, I think, is a really hard one to answer.
I think the one area that I think is missed is the fact of, we're using a lot more PEEP with our BVMs. I think we do a good job teaching to clamp the ET tube, ventilator to ventilator switchover. And where I see it missed is you're using 10 of PEEP on the BVM, and you switch them over to the vent. They're not clamping the ET tube. How much de-recruitment are you seeing in those patients? In some patients, that's probably not a big deal. They don't have a pathophysiology that warrants or that you're going to worry about, hey, we just lost all this recruitment and we're going to have a difficult time re-recruiting. But there are those patients, and the case that we're going to talk about next, in our other podcast, we'll focus on that. What are your thoughts on that?
It's a really good point. And again, I don't know, but you bring up a really good point. It's one of those like mental barriers that if someone says, they've been on 12 PEEP and we've had a hard time oxygenating them and they have COVID and ARDS, it immediately like pings, red flags flying. We got to be careful when we transition this patient, right? But for the patient who's maybe had some pulmonary contusions and it was in a bad car accident and is getting tentative PEEP, and as they've been bagging them up, they've actually been improving. They've been resuscitated by the ground EMS team, and things are going well, and they actually need to be recruited, and they like the tentative PEEP. We have no compunction about just ripping the bag off and then putting them on the bed. So we probably should be a little bit more careful, especially if there's a clinical thread that is suggesting that it was helpful, whether they're on a bag or a vent.
What about the difference between an adult BVM to transitioning to that lung protective, whether that's 6 to 8, we'll just use the range, and that big drop-off tidal volume-wise? What's the thoughts on that?
There is some interesting data that like the volumes delivered in an adult BVM are crazy high. They're all over the place, and they're generally much higher than we think. There was a study that was presented at NAMSP a couple of years ago by Dr. Joe Hawley out of the Memphis area, and the volumes that they were recording from the adult BVM were super high. Interestingly enough, there was that new study that using the pediatric BVMs was not super helpful, and at least a signal in the data. I think that those patients that were, at least they believe they were cardiac arrest patients that were managed with a peds BVM, did not do better. In fact, they may have done worse.
Wow.
And so the thought that it's all about the volume delivered may not necessarily be the case. Now, what we do know is, and I think more and more we've come around to this, is that the pendulum swung after the ARMA trial with the lung protective ventilation and 6 cc's per kilo to the point where people were very dogmatic about it. And what we realized, especially after one of the recent trials that showed essentially that for patients that are not in ARDS, it is actually perfectly safe to ventilate them up to about 8 cc's per kilo. In fact, more than that. I think they were targeting 10 cc's per kilo in the trial. The average person in that group got about 9.1 cc's per kilo, and those patients did fine. The problem is, you don't know when you pick someone up if they have really bad diffuse injury from pulmonary contusions, or you may be able to diagnose ARDS, or it may already be diagnosed, but you may not have that diagnosis at that point, or they may be developing ARDS. So then you got to be careful. I don't have a good reason why sometimes those larger volumes are working, and then transitioning them to the smaller volumes don't necessarily help, other than other changes in intrathoracic pressure that aren't necessarily measured. Things like you're actually putting them on more PEEP consistently than you think now that they're on the ventilator, or they actually stepped up in terms of their average or mean airway pressures and you didn't realize it. The reason that those larger tidal volumes perhaps worked was their minute ventilation was high. And what you really need to do is, now that you've controlled their tidal volume, making sure you have an appropriate rate increase to manage their overall minute ventilation.
Yeah, and I also think you have to look at the size of the patient too. You have certain patients, and I've tried to explain this, that the 6 to 8 mils per kilo is not one size fits all, and there could be patients out there that are maybe obese, or they are just you might have a big guy that's got a big barrel chest or very muscular. That might warrant a bigger tidal volume just to fill the chest cavity, right? Mm-hmm. So I think you have to be open, and I think that's the probably one area that we probably don't do a good enough job. And I know it comes down to guidelines, it comes down to your program specific areas that they focus on. You got to be 50 shades of gray in those areas, right? You got to be really willing to kind of step out and say, hey, this patient is not really handling a 6 mils per kilo tidal volume. We're not seeing recruitment. And so, I think you got to be kind of loose in those areas.
Yeah. And again, if they're on the ventilator, right, you can say, I think it's actually probably safe to go up. Why? Because their compliance looks fine. Their plateau pressure is fine.
Right.
You have lots of data and feedback that suggests their lung parenchyma is compliant and otherwise doing okay, and it's probably reasonable to start going up on those a little bit.
One of the words that you use all the time that I love is reasonable. Right? That's a great word to demonstrate the flexibility that we should have. Now, I completely get we have listeners that might have guidelines that are more protocols where they're pretty set based on their medical director, and so we're not saying to ever deviate from your guidelines or your protocols, but if you have the freedom to kind of work within those gray areas, I think that's where you have to look at your patient, and one size doesn't fit all. I still think about the way I was taught to intubate, and I think it's really easy to fall into the trap of intubate your patient supine. And I think we do a good job education-wise to talk about head of bed elevated 30 degrees and earlobes in line with the xiphoid, and put the towel under the neck and use the geometry to your advantage. But I don't think we do a good enough job to really explain the loss of recruitment that you get when you lay somebody down. And can you just really quickly hit on the importance of sitting your patients up, especially if you have respiratory failure, hypoxic respiratory failure, and how important that is?
There have been a number of studies, and a lot of them are in the anesthesia literature looking at bariatric patients, but even in non-bariatric patients. What we see when you lay someone flat is the pressure of the abdominal viscera essentially pushes up on the diaphragm, and you lose functional residual capacity. So you get atelectasis and loss of functional residual capacity. In some patients, that's up into the 20s or 30%. So when you have a lung volume, open alveoli, and lung parenchyma that's exchanging gas, and then you lose a very substantial fraction of that due to atelectasis and the weight of that viscera just pushing up on your diaphragm, that's pretty substantial. And that is before intubation, during intubation, and after intubation as well. So I think it is actually really, really important to sit those patients up. We have really good data in mechanically ventilated patients. I think we have good data as far as apneic oxygenation is concerned, that period of time that safe apnea time is longer when patients are sitting up. So I think for a number of reasons, and we have good physiologic justification to say they really should, unless there's some other specific contraindication, up at 20 to 30 degrees. And as long as we can manipulate them into the aircraft, I will at least try and get their head a little bit up.
I like to rephrase RSI as resuscitative sequence intubation. So obviously, prior to intubation, we want to make sure that we're passively oxygenating, that we're using, a cannula at, as high as you can go, flush rate if you can, and on a rebreather as a separate source. The pre-intubation phase, again, we're still talking about dash 1A. We're talking about making sure SpO2 is greater than 90. Most programs say greater than 94% before you pull the trigger. And that's always the stopping point, too. When you go below 94%, that's where you stop, regroup, you re-oxygenate. But I think it's important to drive up that SpO2 as high as possible. That's the one time I think we advocate for that. Cause nitrogen washout, really fill the tank, drive up the PaO2, and give yourself that time. But the important piece is to maintain that nasocannula through the entire process, right? Continue using that tool. I see that all the time. I saw that up until I flew. I'd go into a hospital. We'd be preparing for RSI. Respiratory would be by the bed right there wanting to help. And I'd put a cannula on and they'd pull the cannula off. Right? I would get so frustrated. And you have to go into teaching mode and say, hey, we're going to put this on. This is why. But they're so quick to want to pull that off. And so I think it comes down to education. It comes down to we need to be doing the same thing. I think training needs to be part of training as well. We need to be training exactly the way we do it in the field, to where it's just repetition. It's just motor memory. And then maintaining that level of oxygenation after intubation is also part of this phase of, again, up to 10 minutes after we have a desaturation below 90%. That's a failed attempt. So I think we have to be very, very careful. So it comes down to making sure We don't want de-recruitment. We don't want a patient that's maybe on tenofovir where you have disconnection, where you just lost recruitment. We talked about the BVM to mechanical ventilation. That's not going to be every patient. That's going to be some patients. Laying your patient supine probably will cause a drop. So being diligent and if you can, sitting that patient up. And then having a good high index of suspicion of what the patho is. Is this a trauma patient with pulmonary contusions? Do you have simple pneumos that could progress to, a tension? Or is this a patient that has lung disease and you're dealing with something much bigger? Is this a sepsis patient? Is this somebody that's progressing to ARDS potentially? Is this somebody that could be an ARDS candidate? Because remember, most ARDS patients are indirect lung injury patients. They're not direct lung injury. Definitely a category, multiple areas that cause direct lung injury, but a lot of patients end up in ARDS that did not necessarily come in with lung injury. Is that correct?
There's definitely a substantial group that are not directly injured. I actually forget the number of patients that develop pneumonia and then get ARDS, and it is more of a direct injury. Right. But there is a very significant group that develops ARDS from extrapulmonary sources.
Okay. And then lastly, right, we teach this all the time in mechanical ventilation, consistently assess your dope pneumonic. And this is just really quick. Make sure you don't have any dislodgements. Make sure there's no obstructions. We're going to talk about suctioning later on. Do you have a good high index of suspicion of a simple pneumo to where you can take care of a tension? That should never be a surprise. If in doubt, I always say, I want your thoughts on this. Decompress the chest, right? Don't wait to see changes in vitals, SAT, things like that. Those are late signs. And then just make sure you understand your equipment. Do you have enough oxygen? Do you have disconnections? I saw that all the time with the LTV 1200 and the Ravel, where your clear tubing would come off, especially the LTV 1200, and you'd get a low O2 sense alarm, right? That was a simple, but you would stop ventilating the patient just based on that clear tubing. So little things like that will go a long way in preventing the hypoxia.
Yeah, and I would take it one step further, and I really been meaning to do like a podcast on this. I think action-focused intervention is probably the best thing you can do, like almost like a drill. In other words, instead of saying, what I see all the time is like dopes and people sit there thinking, well, is the tube in? Do they have a pneumo? I don't know. Well, when someone's really sick and they're hypotensive and hypoxic, I would say you should empirically go like ruling those things out, not with just like cognitive forcing and thinking about it, but rather displacement. We should be training people to look at the vent. Are you getting good volumes back? Do you have end-tidal CO2? Grab the laryngoscope that you use to intubate them and look and see if it's between the cords. Then move on to obstruction. If you have a Ballard or you have a suction, I am actually a big fan of putting a Ballard on every circuit so that you can reach down there. And if you know that you can get the suction all the way down the tube, it's unlikely there's an obstruction in the tube itself, which you can do something about. Pneumothorax, training people not to just think, well, do they have a pneumothorax, but getting the ultrasound, putting it on the chest and definitively saying there's lung sliding or there's not lung sliding, and here's what I'm going to do about it. So instead of just having, I believe, that's a great mnemonic. What I think we need to do is instead of having people think about it, train them to empirically rule those things out really, really quickly, like in 2 minutes or less.
I think it comes down to being proactive, not reactive. We talk about that all the time in airway management, but I mean, I think all of these pieces of the acronym FACTORS, it's being ahead of the game or attempting to be ahead of the game and trying to head this stuff off to where even if you're just aware of it, it's not so much that you have to take action all the time. It's about an awareness. Let's move to A, and A is acidemia or acidosis. And I really want to just briefly touch on this. I mean, I don't want to spend a lot of time in this area, but I think also from an education piece, I don't think we do a good enough job. I think we just routinely say, hey, any metabolic acidosis patients have to have a high minute ventilation. And I would have to admit, for the longest time, I think I had that mindset. I think it's interesting to think about. But then, as I've progressed in my knowledge and been surrounded by physicians that have maybe sometimes educated me, corrected me, or been willing to sit down with me and really talk about it, There's probably just a few different types of patients that you're going to truly see significant partial compensation where you need to match that mid-ventilation. So I want to talk about that because I think that is definitely an area in mechanical ventilation that I see as really important. I truly believe the number one ABG to be able to identify is a partially compensated metabolic acidosis. And I think that is something that is difficult for people to recognize. And so I just wanted your thoughts on that, and then I'll go through really quickly an acronym that we teach, Goldmark standard, right? It's standard in medicine now. It's replaced the whole cat mud piles. But I wanted your thoughts on that, and then I'll kind of touch base on some of these areas that I think are important and get your thoughts on that.
Yeah, so I think it is very important. It's not just if they're breathing fast, and I think you brought up a really, really good point on this, because patients with intrinsic lung disease can breathe fast. That doesn't mean they have an acidosis. Patients who are hypoxic can be breathing fast, and they may actually be a little alkalotic. Yeah. So there's a lot of patients that are breathing fast or breathing heavy and are in respiratory distress, but they don't necessarily need a high minute ventilation. I think that's important because giving people high minute ventilation on the ventilator is not always a good thing. Breathing faster for them and pounding air into their lungs more times a minute. So if we don't have to, it may be reasonable not to. But like you said, those patients, especially those patients that have an anion gap, metabolic acidosis that's partially compensated, and the way they're hanging in there by their fingernails, especially the ones that are relatively common, like our DKAers or our toxic metabolic or our toxic ingestions and things like that, those patients really can't tolerate apnea very well and loss of their minute ventilation. It's what's allowing them to hang on. It is their fingernails. That's what's keeping them from falling off the cliff. And appropriately identifying those patients, which can be hard, especially when you're doing like a modified scene flight or a medical scene flight or something like that in a very rural area, can be super, super challenging. But we have to be on the lookout for it and at least consider it, and then confirmatory testing with point of care labs. And in this setting, I think is actually a really good idea. And then especially if they have labs at an outside hospital, you can get a ton of clues as to what's going on, and then be prepared to match that minute ventilation and help them compensate for that acidosis.
So I'll say glycols, aspirin overdose probably, right? Ketoacidosis. Yep. Those three probably are going to be ones. You probably would see this in a metformin-related lactic acidosis, right? Mm-hmm. But I think that they're going to be ingestion-based in a lot of ways. Obviously, DKA is not, but it's not every patient. And I think you gotta look at the trade-off. And I think it comes back to our first point of positive pressure. Well, positive pressure and changing from negative pressure breathing to positive pressure breathing, there's a trade-off, and it kind of translates to, well, what is the impact of a fast rate? And that is more anatomical dead space. And that anatomical dead space is a factor in increasing intrathoracic pressure, right? Decreasing venous return and causing a decrease in cardiac output. So I think that is a problem with lung protective ventilation, and especially those higher rate situations. We have vasopressors. We have other ways to try to counteract that. But that's a trade-off, and that's something you have to be aware of. And so my point of that is we can't just use a blanket. Every metabolic acidosis patient needs a fast rate, because there's a negative trade-off to that you are impacting your patients negatively.
Yeah, 100%. There's essentially nothing that's free in any of the interventions that we do.
And that goes to the next point, is cardiac output. So C is cardiac output. What I really want to focus on is an area that we spend a lot of time in our courses on, defining stroke volume and defining the impact on demand. Cardiac output is not as simple as just saying stroke volume times heart rate. Right? Heart rate's easy. It's either too fast, it's too slow, or it's normal. And we can usually figure out why that is. Stroke volume, though, is multifaceted. And so I really want to focus on that piece and your thoughts on optimizing each phase of that and recognizing how we change those phases.
This can be really challenging with limited diagnostic tools. Sometimes I feel like I get spoiled in the emergency department and the ICU because I got a billion tools at my disposal, and often a lot of diagnostic information. And then I'm usually humbled flying around and picking up patients because I don't have all that information and I'm trying to make decisions. But I think thinking about it, I think about the heart in terms of right side and left side, and then preload, afterload, or preload, inentropy, and afterload on those individual ventricles. There is some degree of interventricular dependence, and they're not completely isolated. But if you can kind of wrap your head around right side lungs, left side, and what comes before, the intrinsic inentropy of that ventricle, and then what's coming after, I kind of break it down in my brain that way. And if I know someone has right heart dysfunction, pulmonary arterial hypertension, or I echo them and I see a really strained, blown out RV that's not squeezing very well and their TAPSE super low, and you can just see that it's really strained and underfilled left ventricle, I know that there's something going on with the right ventricle. There's acute RV strain. How do you address that? Well, I think about before, the right ventricle itself, and after. A lot of the times, unless they're having an MI, it's something that's going on after in the lungs. Well, how do I reduce the afterload? That's the question, right? You can make sure that we optimize the recruitment of their alveoli and minimize the afterload on the RV by optimizing their functional residual capacity if they're not intubated, or if they are intubated, recruiting as many alveoli as possible. We can think about oxygenating them. This kind of goes back to hypoxia. Oxygen is like the OG pulmonary vasodilator, making sure that's in place. Thinking about things like inhaled pulmonary vasodilators. If I think it has to do with the RV itself, we think about, okay, so how am I going to increase the inentropy of the right ventricle? We can use epi, you can use dobutamine, you can use a variety of things. If it's preload, how can I get preload off? Can I reduce that pressure? Can I use increases in intrathoracic pressure to decrease preload on the RV? That's an option as well.
That's a good one.
Yeah, so you can think about it in a number of different ways. And if you break it down into right heart and left heart, and then think about what's going on before, inside, and after, I can think about how am I going to optimize that for someone.
Yeah, I don't know if you guys heard what he just said, but basically he utilized the piece that we were talking about before about how intrathoracic pressure causes a decreased venous return. And now you're saying, well, what if I have a high right-sided overloaded situation, which the heart doesn't like. It does not like a high pressure right side. Unless you're a newborn baby, and you're just born, that should never be. And so now you're using that high intrathoracic pressure or ways to increase intrathoracic pressure to reduce that. So I love that.
And to be clear, it's not all RV failure responds the same.
Right.
If your RV failure is due to LV failure, just like we know that CPAP and BiPAP are super helpful, decrease preload and actually cause a relative decrease in afterload on the LV, it can be super helpful. If your RV failure is secondary to a huge PE or pulmonary arterial hypertension, you got to be really careful with PEEP and positive pressure. That could be really bad. So it comes back to like what you think is going on and the underlying driver in that patient's underlying pathophysiology.
This is bigger picture stuff, but behind the scenes, cardiac output times CaO2 is the delivery of oxygen, right? Ultimately, that's what we're focusing on. We don't really think of it that way. We think of it that way. Maybe you're measuring that in the ICU, and I know we've talked about that, and you're definitely measuring what is my delivery versus what is my demand. But we're not thinking about things to that level. At least I don't think we do that well enough. And I think we should be just in our mind thinking, okay, what is this big picture? And I think critical care that's what that is. An ALS provider is not looking at big picture. Critical care is looking at big picture. You, now that you're done with your fellowships, if you could reflect back when you finished residency, I'm sure you're even bigger picture, right? Because you understand things to a broader perspective. And I think that's what medicine is about. And it comes down to, can you take that information and then apply it to these patients in the right way? I think that's the key. So what's one way for us to improve cardiac output in that rapid sequence intubation, or again, resuscitative sequence intubation phase? I want to kind of talk about the push dose pressor. How should that be used? Should we be using more of this? Should we be more aggressive? Right. Again, we don't want to drop in systolic less than 90. And a lot of programs, talking to Jacob Miller from University of Cincinnati, their program, they focus on systolic of 100. Mm-hmm. Right. They're a little higher. And I think that's probably a safe place to be. So what are your thoughts on the role of a push dose pressor in that? And should we be more diligent? And then what do you think the best push dose pressor is?
Ooh, oh man. I think that's that is a highly controversial question and hard to say, but taking a step back, again, I just keep circling back to, and this is why I think critical care is so cool, and what makes pre-hospital critical care even more challenging is thinking about the patient's pathophysiology. Like, what is going on with this patient? Because really, in my mind, I think push dose pressors are great, but I consider them like a parachute or a safety net. There is some literature that suggests that just giving it to everybody empirically doesn't necessarily help or improve things or prevent hypotension. And that's probably multifaceted, right? If someone's hanging in there, but they're profoundly hypovolemic and you give them a little bit of push dose pressor, but then give them a bunch of sedative and then transition them over to positive pressure, the little bit of push dose pressor is probably not going to help. Thinking very carefully about, like, if they need pressor to begin with, making sure they're on an infusion, making sure it's hanging and they're getting it before the intubation is going to be really, really important. And then bumping them up a hair is probably very reasonable, and I think it's good to have that as a safety net ready, because if they need it, I mean, we've all seen it. Sometimes they need it really quick, and right. Fumbling through your bags, trying to mix it up at that point is a terrible idea. So I think we should have it ready. I don't necessarily think we should be giving it to everybody. In general, I try to think about, and there's really no data to support this. It's just practice. My practice is thinking about, is this more vasodilatory? Do they need more cardiac output or not? If they don't really need more cardiac output, and I think it's the majority of it is vasodilatory. They're septic. That's probably number 1, 2, and 3 on my list, right? Then I think it's reasonable to do push dose phenyl or push dose norepinephrine, or in some cases even push dose vasopressin. I've used that in the ICU. If I think that they will benefit more from increased cardiac output, then I'll go with the push dose epi. And that's largely, I would say, would be my default, especially in the pre-hospital trauma population, and a couple of others. Although I think there's more and more, I've been toying with the idea of using vasopressin for those pre-hospital trauma patients, especially if they're young and they do have a healthy heart.
Dave Olvera, led that study, the Viper study with Air Methods, and they compared vasopressin, epi, and phenylephrine in the trauma setting, and vasopressin outperformed all 3 of them. Mm-hmm. So there's definitely, a small subset of patients that showed benefit. I think the negative side we see is the cost of vasopressin is so high. Mm-hmm. But definitely something that I would agree with. I think it's probably a better choice in trauma.
And after reading those studies, yeah, exactly. I think for a lot of programs it is. I think if you're already carrying it, though, like we for example are, and this is one of those things that the data was out there, but I was very hesitant to do it until some of my anesthesia colleagues got me more comfortable with it. Now I'm like, maybe we should be doing this. Maybe a unit or 2 of vasopressin isn't such a bad idea.
Yeah. So the next one is really transfer. So T is transfer. And so I think, we've talked already about positive pressure. We've talked about hypoxia, acidemia, cardiac output. So now I want you to kind of think about we've successfully intubated. We have ET tube confirmation. We've packaged the patient. We have the ET tube confirmed. We've measured at the teeth. We've got a good waveform. We've got a good SpO2. Our systolic is greater than 90. And now we have to move the patient. What are your top 3 things you're looking at? What are you preparing? What are you doing to ensure that you don't have a decompensation? Do you have a pre-filled syringe ready to go push dose pressure wise? Are you giving them, what if they're right at 92 systolic, right? SpO2 is 94%. Are you giving them a bump? What are your thoughts? And then think about the situational awareness. What's the difference between hot versus cold loading? Does that make a difference in your decision?
So the 3 things that I really try and focus on are lines and tubes, access and drugs, and good situational awareness. And the reason I say that is because you think you have everything organized and the spaghetti ensues as soon as you put them in the hypothermia wrap. As soon as you get them in the life blanket, I think we've all seen EKG wires, endotracheal or vent tubing. We've seen IV lines get caught on corners, seats, equipment, you name it. So I always think about, is everything streamlined? What is going to get caught on what and what's going to pull out, and how do I prevent that? Both in the packaging and then throughout the movement to the aircraft. Access and drugs. It kind of leads us into our next one really well, but I would say that continually having a point that's exposed or easy to get to push emergency medications, to push sedation and analgesia, and to give them whatever other medications they may need, or blood products, for example, is so key, because I can't tell you how many times I've been caught with my pants down moving from the ambulance to the aircraft, and all of a sudden they're hypotensive, and then you're opening up the life blanket and you're digging to try and find that IV that's in their AC, and, desperately telling your partner, give me the push dose epi, or give me the blood, or whatever. Having it easily accessible, like, hey, it's right up here, like the port is right up here at their right shoulder. If we need anything, like, that's exactly where we're going. And the drugs out and available. Putting everything back in your bag, I would at least keep some push dose pressor, analgesia, sedation, and then if it's a trauma patient, you should probably be already prepping and giving them, or have the next unit of blood ready to go if they're really hanging in there. And then lastly, the situational awareness piece. I constantly think about scanning my partners all around me, looking at the monitor, looking at the vent, looking at the patient, because things can change in an instant. And when you're busy trying to load someone, I feel like it's very easy to neglect a end tidal CO2 that's drifting down, or a heart rate that's really going from 100 to 90 to 60 to 50. So really trying to focus on staying on top of those things is important.
Yeah. And I think you add, are you loading hot versus cold? I think in my career, especially scene flights, you're probably loading hot. You also have the element of EMS and fire and the LZ, and everybody wants to come to the aircraft. And so you have to select just a few people, and you got to worry about hats, and you got to worry about the blankets, and you got to, right. You really aren't focused on the patient. I mean, let's just be honest. You're not. So, your patient ends up being maybe a secondary thought. It's just a couple minutes, but it definitely is a problem. And so I think you have to be very focused, and that preparation prior to moving has to be there.
And I actually think this is one of the reasons why we should potentially consider, just like we're doing lights and sirens less, we should consider hot loading less. I don't think with current technology and a lot of the aircraft that are in the industry, it makes a lot of difference. In my experience, starting up the helicopter is not the limiting, the limiting factor, right? There are some arguments, and sometimes when it's probably reasonable, but I think by and large, it's a practice that we could probably be limiting, or at least thinking about more carefully. It's loud, it's distracting, it's hard to communicate. We lose track of the patient because our situational awareness is focused more on the people around us and safety than it is the patient. Whereas a lot of the time you could probably just load cold, keep a better eye on the patient. We can talk at the volume that we're talking right now. I think for a lot of reasons, we may want to reconsider that.
I think there's times, obviously, you land on the middle of a freeway, because there are those times where the aircraft doesn't want to start, right? Or something happens. So maybe that's a time where, let's just be honest, sometimes that's a big billboard sitting out there you don't want sitting out there not started, and you got traffic backed up 20 miles. Next one is going to be ongoing pharmacology for O. And man, this is one that there's so many ways we could go down. I think we've seen a big shift in the industry over the last 10 years. When we were talking to Scott at dinner, and he was talking about his study that he did with Rich Levitan, where they were talking about the preoxygenation and the whole desaturation between succinylcholine and rocuronium, right? I think that there's been a lot of change in the industry, where not only that, but there's the study by John Sackles that I saw is very influential in maybe steering medical direction away from succinylcholine being the first line paralytic. And I've seen a lot of change pretty much US wide, where rocuronium is the first choice. That changes the dynamics. Yeah, I think it's a much better medication overall. Probably less side effects, definitely less side effects. But you also have a patient that's much different. And I think for a lot of us that learned with succinylcholine, and I know for me, I was always hyper aware. I knew when we moved from the ambulance to the aircraft, by the time we hit the aircraft door, my patient was probably going to be moving at that point. So I was pretty diligent about making sure I was giving my sedation and pain management. And it's human nature to miss cues. And so are we being good stewards of our patients? And are we giving ongoing pharmacology from a pain and sedation standpoint in the right amounts? And I think I would have to say in my consulting side, reviewing different charts and talking to different programs, I think that's a problem. I think we easily miss. We realize all of a sudden 15 minutes into the flight, we haven't given anything.
I think you hit the nail on the head. I think if they're not like biting on the tube and causing problems a lot of the time, we forget about the time because we're so busy. There's so much other stuff going on. And without them bringing us our attention to it, we forget. The ED Aware trial, I think, was like 2 to 3% of patients. There was another study recently, I think, that Brian Driver's group released where they quoted rates up to 7% of what the investigators perceived as awareness under paralysis. People saying that they could not move and they remembered what was going on or had some memory of what was going on. That's bad, right?
That's terrible.
That is awful. I mean, I can't even imagine how that contributes to the psychological trauma of everything that's going on to this person. So we do have to be more diligent about it. The rock versus sucks argument continues to wage on. And when I see smart people on either side advocating for both, I even struggle with this question myself. I do. Personally, confession, I use a lot more rocuronium, almost entirely rocuronium. But when I do that, I'm very diligent. As soon as they are hemodynamically stable after the tube goes in, they're oxygenating well within minutes. One of my first priorities is to have those sedative medications ready and giving them a little bit of midazolam or starting the propofol or dexmedetomidine or whatever. I think that's really, really important. Now, what I've tried to do is cue myself. As soon as I get to the aircraft, we get settled, we get buckled. Do they need analgesia or sedation? That's like my cube is like buckling in. Do I need to give this person analgesia or sedation? Because you need to have those cues or cognitive stop points that are kind of burned into your brain, because without them, the patient may not tell you.
Yeah, and I think that's something for you guys out there is maybe try to associate that with a task that you do every single time. Mm-hmm. Hey, I'm buckling in. Whatever it is, you need to associate that with what you do in your program, in your aircraft. But associate that because, I've seen that in malpractice cases as well. You have issues that happen just simply based on, I have one case that I talk about all the time where you have this flight crew that's 12, 15-year flight nurse, flight paramedic that performs at RSI on a near drowning that does everything absolutely perfectly. They're proactive, not reactive. They do everything by the book. They give rock. They don't sedate and give pain management. They're 18 minutes in, 20 minutes in, and all of a sudden the patient wakes up, pulls the ET tube, and now they have vomiting. And now they're reactive to a situation, and things go completely the opposite direction, right? And so it's the same crew. I share this with our courses because I think it shows us that I don't care how much experience you have, how much flight time you have. If we're reactive to a situation, I think it goes back to also maybe strengthening the argument of stress inoculation training.
Yeah, I could not agree more. What I always tell people, it has nothing to do with your level of intelligence.
Yeah.
Your ability to solve problems. What's going on is your brain is just completely saturated with all sorts of other stuff. And you have to come up with ways, behavioral interventions, essentially, to force yourself to think about some of these things. Because just saying, I'm going to think about it, rarely ever works when your working memory is completely saturated by everything else that's going on. And so things that I help, we're coming up with those things that fit in with your workflow really well. I think it also is, some institutions will use post-intubation checklists or takeoff checklists that actually prompt them to do it as part of a routine post-intubation package. I think that's also reasonable sometimes. So, and there's a lot of ways to do it. We just have to build in functional fixes that allow us to make sure that we are remembering and we're doing the stuff.
Let's move on to really the thoughts of how often should you be dosing? There's definitely misconception on the half-life of fentanyl. Mm-hmm. The hemodynamic impact of fentanyl. I want to talk about that. And then How often should we be dosing our ketamine, which is probably the most standard ongoing sedation drug? I mean, obviously, I think a lot of us, I used Versed for the most of my career. And so I would dose that every 10 or 15 minutes. But talk about your thoughts on that, and then we'll move on to our resuscitation part.
This is something that I think we need to talk more about in the industry. And the reason is because we teach people all of these numbers. The half-life of ketamine is 20 minutes or 30 minutes. The half-life of these medications is XYZ. Well, that's all from healthy volunteers, animal studies, bench research with people with normal hemodynamics, not critically ill people. And what we do know is that from a lot of the anesthesia literature, in people with reduced cardiac output, they have biochemical changes in their blood that are causing serum concentrations to be slightly higher. Their volume of distribution changes because they're not redistributing a lot of these very lipophilic drugs like ketamine and fentanyl into their peripheral tissues, right? They're staying in the central compartment because they're very clamped down because they're profoundly hypotensive from blood loss or profoundly vasodilated, right? So I think that these perturbed physiological conditions make it so that we don't always know exactly what the half-life is, but I think we can be pretty well assured that it's not what the book says it is. And it is probably less for a number of reasons. So whenever we see the half-life, I think we all have to ask our question, is it the half-life elimination? Or are we talking about the half-life of redistribution? The half-life is not always necessarily the time that drug has a clinical effect. And do we have to start thinking about perturbed physiology in critically ill patients? And that's changing how those medications are acting on their brain and managing their pain and making them forget. And I think by and large, that means we probably should be giving these medications more often as long as their hemodynamics will tolerate.
You know, I think what I usually tell people is I think you're pretty safe giving fentanyl every 5 minutes. I think it's probably better to give the lower dose, and you can always give more. That's probably the safer option. And then, you just give your sedation drug every 10 to 15, and you get into a systematic approach of doing that. And again, I love the pre-lift checklist of, all right, we've moved out of the ambulance or the hospital. We're in the aircraft. We're about to lift. What do we need to do right now before we lift or during lift, right? Make sure you get through the sterile flight considerations and eyes out. So there's a lot going on. I get it. But there's got to be some trigger to, we have to do a better job in sedation pain management. We just have to.
And that's, I think, one of the arguments that probably the best assessment is using validated scores like a RASS, looking at their level of agitation and sedation, a CPOT score. These things we can probably extrapolate from the ED and the ICU. It's hard when someone's paralyzed, right? Because you have to be really, really on top of that because you won't get some of the information for either of those scores. And then I think you're absolutely right. This is one of those things that differentiates the transport environment from my lovely warm ICU that I can walk around with coffee in hand, right? Is that there is so much going on and the environment plays such an important role in safety because of what your brain has to deal with to maintain safety that we can't always be reliant, or it's really not practical to say you have to do a RASS or a CPOT score every 5 minutes, right? I just don't think it's practical.
I think that's a great point. And I think that moves us to our next section, and that is when we look at ongoing resuscitation, right? We talk about the peri-intubation phase of making sure that we are resuscitating our patients, we're filling the tank, we're making sure our hemodynamic status is stable. We can't forget that we have to, number one, have the indication. And what I want to focus on is probably one of the best indications. And I think trauma, there's definitely literature to support this, shock index. Right? And so I think shock index is not explained fully, but really shock index greater than 0.9 or more. What does that mean to you? And how do we take care of ongoing resuscitation after the fact, which comes back to this whole acronym, the factors that we need to be either assessing, evaluating, or dealing with in that 10-minute phase that is going to prevent them from having either a desaturation or a drop in hemodynamic status below those thresholds. So how do you look at shock index? Does that translate to mortality?
So I think in certain populations, there's pretty clear data that it correlates really well with things like increased mortality, the need for increased transfusion, and a whole bunch of other variables. So I think it is actually really important. My litmus test, my quick test at the bedside is looking and saying, is their heart rate greater than their systolic blood pressure? If their heart rate is greater than their systolic blood pressure, by definition, they're going to have a greater shock index than 1, right? Which is definitely above 8 or 9. But if it's close, I'll start to actually do the numbers and say, well, is it actually 0.9? Should I actually be worried? And what it tells me is that even though someone's not hypotensive, there is a reasonable likelihood that their heart rate is driving a cardiac output that is keeping their blood pressure up. That concerns me because they're in a compensated state. If we give them maybe a little too much sedative medication, maybe a little too much analgesia, we do anything that can push them over the edge. We increase their intrathoracic pressure just a little bit too much. We got to be very careful and thoughtful about our interventions and aggressively pursue why is their shock index high? What is the underlying driver here? And putting that together with all of our clinical examination tools, ultrasound and rush exam, every other piece of data that we have available to us. So it's really like the red flag warning to me that this person's in a compensated state. They're heading the wrong direction. We have to aggressively figure out what's going on and try and fix it.
So you said something that I want to expand on, and I think when I went to paramedic school a long, long time ago, even going back to EMT, I was taught you have compensated, which is, hey, you have a heart rate that's elevated, blood pressure is still normal. And then you have decompensated, you have a heart rate that is elevated and blood pressure is now hypotensive, right? And now we've seen a shift to where I think the threshold has lowered to where really especially in trauma, right? Heart rate 130 or greater, is that truly compensated, or should that be looked at as decompensated shock? I've been able to present this to thousands of people, and I hear these questions. And the common question about shock index is, well, man, you expect me to do this math right there in front of a patient, pull my calculator out? And so my response is obviously it's changed over the years to where now I'm pretty focused on looking at the big picture. And what I tell people is this: if your heart rate is over 100, assume your shock index is greater than 0.9. Or simply say, is your heart rate greater than 100 and your systolic less than 100? You're over 1.
Yep. Yeah,
right?
I would say
so try to make it simple, and I want to be hyper vigilant in making sure that I am prepared for those points that could cause decompensation.
Yeah. And I think you brought up a really good point. And one of my mentors brought this up. He said, there's a difference between compensating or kind of compensating and compensated. And rarely is a patient compensated. Rarely do they have a heart rate of, 140 and then they have critical injuries and they're in shock and their systolic blood pressure is 120, right? Usually it's the heart rate of 120 to 140 and a systolic blood pressure 100, 109, something like that. And that person is not compensated. They're hanging in there with their compensatory mechanism, but they're incredibly high risk of decompensating in my mind.
At what point during that 10-minute phase are you saying, all right, we've got blood going, we've started some volume? Not every place has blood. Let's just be honest, right? I think we've seen a big increase in the focus of not only blood education, but ground agency using blood.
Yeah.
One of our associate medical directors, a close friend of yours and mine, is Peter Antevy, right? He is hyper vigilant right now about pushing blood. He is on fire.
He is on the blood bandwagon for sure, man. Which is a good thing. Again,
going back to the push-dose pressor. It's like a Band-Aid, putting a Band-Aid on a femoral artery laceration, right? You gotta fix the problem. Push-dose pressor is not going to fix the problem. It's going to give you maybe some time, but you can't squeeze something that's not there, right? So is there any element to giving a push-dose pressor if you haven't resuscitated truly and filled the tank?
There's two sides of me, right? The academician and the practicalist. The practicalist is the dude that's worked in the field and been deployed and understand what it's like to be, out there on the side of the road in the middle of the night. And the academician is the one who reads the data and really tries to be on top of things. And I think the process of becoming a clinician is the process of reconciling those two things. And in my mind, right, it is folly to say you should never, ever give push-dose pressor or pressor to a trauma patient. Why did you give them pressor? Well, if the clamshell doors are open and we're about to load someone and their blood pressure cuff comes back and it reads 80/40, if there's no clear contraindication, let's just face it, you're going to stop underneath the tail boom and you're going to hook up the blood and do all that stuff. Even if you know that's what they need and this is sudden, let's say you just finish your first bag of blood and this is what's going on. Giving them a little bit of epinephrine to keep their blood pressure up, especially in the setting of other concomitant pathology that we know does not do well with hypotension, like head injuries. Totally fine. I think you can justify that. The mistake would be basically continuing to push that all the way to the hospital and not giving additional blood or other products, or not trying to better differentiate what's going on. Do they have a pneumo? Do they have a pericardial tamponade? Do they have blood loss from another area, and then not give the blood? That would be wrong in my mind. Right. But as a temporizing measure, until we can get what they really need, I think it's reasonable. I also think, especially in the setting of trauma, I get used to this in the hospital of having an unending supply of massive transfusion and a level 1 infuser or a Belmont that we can just jam blood into people. How much blood is the average? If a program is carrying blood, how much they carry? A couple units of reds, a couple units of plasma, right? Maybe some organizations are getting the bigger blood boxes and actually carrying 3 and 3 or whole blood or other things, right? But it's just not the same. So someone who's exsanguinating and you've done everything you can, they're bleeding internally and you're giving them every drop of blood and plasma, is it wrong to give them a little bit of vasopressin until you can get someplace that can provide definitive care? I don't think so. I would certainly prefer that than to see ongoing hypotension.
And I guess the point of that is we have to be hyper vigilant and aware of ongoing resuscitation. Resuscitation doesn't stop. Again, go back to Napoleon's quote of the most dangerous moment comes with victory. Again, resuscitation doesn't stop once that ET tube passes the vocal cords. We have to continue that through that whole process. So the last little section here is suction. And it's probably the most under-respected. Who loves to suction? I don't think many people love to suction, right? It's probably one of the last things we truly want to do or think about. But let's talk about just really quickly the benefits of this, right? We obviously, I think there's a point, and I think from a paramedic standpoint, this isn't something that's very well taught, is ventilator-associated pneumonia and the prevention. And that goes all the way back to the peri-intubation phase of using Decanto-Sala technique and training and teaching. The first thing that goes into the oral pharynx is a suction catheter. And the last thing that you remove should be that suction catheter. But I think good awareness of your cuff pressure and controlling the secretions and making sure that you're suctioning that ET tube and how that optimizes oxygenation and ventilation. Does that have an impact on recruitment or atelectasis? Some of you guys might say atelectasis, but we were having that debate prior to this podcast. Again,
I'm in the atelectasis group, by the way.
Yeah. I like to say atelectasis. I think I heard European doc say that, and I thought that was pretty cool. So.
Yeah, was that doctor an anesthetist by any chance?
It was, yes.
Right.
Same doctor that said sonometer.
I think it can. right? In some patients, especially if their stomach is insufflated, it can cause problems. In fact, just the other week in the ICU, we had a patient with that we didn't realize until we got the first chest X-ray that had a pretty significant hiatal hernia, and her stomach was up in like her right hemithorax.
Wow.
And so we were having all sorts of issues, and in the end, one of the things we had to do was decompress her stomach, and a lot of things got better really, really quickly. Now, that's pretty rare, right? But in general, decompressing the stomach is probably a good thing, especially considering a lot of our patients are not necessarily fasting, getting whatever we can. Although, if with my luck, the hamburger that they had 15 minutes before they got on their motorcycle, probably not going to come out through an OG tube, right? Decompressing it's probably a good idea. And you brought up another really good point, because we've been talking and focusing mainly on trauma, but the vast majority of our calls are interfacility transport, and the vast majority of intubated patients that we manage have already been intubated, sometimes for a little while. And when the ED is busy, we don't always do a very good job of like starting good oral care, putting in an OG tube, trying all of the good respiratory preventative techniques to prevent iatrogenic injury from tubes, and like you pointed out, pneumonia. And I agree with you 100%. I never got good education on that as a paramedic. They do it in the ED, or they'll do it when we get to the receiving hospital. But it's probably important to consider if you have the cognitive space, and especially if someone is resuscitated and stable. Those are good housekeeping things we should be doing.
I think when you look at this acronym, this is an acronym that we want to utilize and expand on. It's definitely an acronym that we want to utilize to highlight the areas of resuscitation and that 10 minutes after intubation that I think is very often missed. So again, just to recap, remember factors that impact that post-intubation phase are, number one, positive pressure. Understand the impact of going from a BVM to a ventilator, or just going simply from negative pressure breathing, the standard physiology that we all breathe by, to positive pressure. That has a huge impact. And so we have to understand that. Sometimes it's not about us making a definitive change, because there's no surrogate. You have to transition them to positive pressure. But what is that impact? What is your awareness of that impact? Hypoxia. Think about what is impacting hypoxia. It comes back to simple things: sitting your patient up, head of bed elevated, gaining recruitment in those areas, thinking about the patho that's involved in this patient, thinking about the peri-intubation phase and how you are managing that pre-oxygenation phase, cannula, non-rebreather, always making sure your BVM is set up and ready to go. Make sure a PEEP valve is applied in case you need to use it, using end-tidal CO2 on your BVM ready to go to where you're not searching for it right when the ET tube is passed. Remembering that acidemia is not just a blanket term that every patient that you come across that is in an acidemia doesn't need necessarily a high minute ventilation. Remember that cardiac output is not just as simple as heart rate or stroke volume, that you need to define what stroke volume is and know how to impact and assess preload, afterload contractility. Think about the transfer phase. Moving your patient from the hospital to the helicopter or fixed wing, or from the ambulance to the aircraft. That is a phase that has to happen. You have to be prepared. You and your partner are worrying about a lot of different things during that 10 minutes. So being prepared, making sure you're packaging your patient accordingly to where you can access your lines, to where you have safety in mind, that you're aware situationally, goes a long way so you prevent any problems. The next one, ongoing pharm, where we talked about just our awareness of sedation and pain management. And, we're using that longer acting paralytic like rocuronium a lot of times, maybe using a checklist when you get in the aircraft, or as Mike said, hey, I've got a trigger. When I seatbelt in, when I buckle my seatbelts, I know I've got to start thinking about my pain management and sedation. Think about ongoing resuscitation. We started this in the peri-intubation phase. We started this in the airway assessment phase. We've got to continue that all the way through. And then suctioning our patient, good ventilator-associated pneumonia awareness, and getting rid of the secretions, and making sure that we understand the impact of oxygenation, ventilation, and the impact on recruitment or the loss of recruitment. And so suctioning is definitely one of those lost areas that I think we often miss. And it comes back to also, right, we don't have this as part of this, is every intubated patient should have an OG or NG tube placed, decompress that stomach. And I think that is good care. So as we talked about, guys, factors go alongside Scott Weingard's HOP killers, right? HOP killers really focus on that pre-intubation thought process. What are those killers? Factors are really those factors that impact that post-intubation phase, that 10-minute phase afterwards. And I think that's where a lot of problems happen. That's where a lot of patients start declining. Dr. Lauria, what are your final thoughts?
My final thoughts are, I think this is the next step in the evolution of good airway management and critical care, right? We focused on, I think the stuff that Bill put forward with -1A, thinking about more than just getting the tube in on the first pass and carrying this patient safely through was brilliant. All the stuff that Scott's been talking about and the work that others have done on focusing on resuscitative care, transitioning someone to intubation and receiving positive pressure and sedative medications on this continuum of resuscitation has been very important. And this is the next step. I think this is looking at and managing and at least focusing or putting some more thought on what is happening after the tube goes in that first 10 minutes. And I think it's been somewhat undervalued up until this point. And I think that now we have the other things down. We really need to start focusing on, the HOP killers before, during, and incorporating them into factors after, as well as all of these other really good things. And I think our patients are going to be better off for it.
Nicely said. Well, guys, hey, if you have any questions you want to hear other topics related to this, definitely reach out to either of us. And we thank you for joining us, and we'll talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.